This conference will now be recorded.
Okay, just briefly for those who missed the first part, who may be watching the recording, this again is the first in a series of telehealth listening sessions. This one is for healthcare providers. We're going to be hearing from some brief background on telehealth from state agencies, and then we'll be hearing from a group of providers from all across the state with their experiences about telehealth, and then we'll open it up for an open forum for everyone involved on the call, so they can share their experiences and thoughts about next steps. So as most of you know, probably, DCBS and the Division of Financial Regulation regulates insurance in the state of Oregon, and that includes commercial health insurance. Before the COVID-19 pandemic, we did have a requirement on the books for health plans to cover telehealth, but it is a somewhat limited requirement. It only requires coverage for telehealth services delivered via two-way video conference, so it does not include telephone or other kinds of app-based versions of telehealth. And it also has no particular requirements around reimbursement or out-of-pocket costs. Since the beginning of the pandemic, starting in March, we have worked with OHA and stakeholders to release some guidance on telehealth coverage and access through both commercial insurance and CCOs in Medicaid that expanded the coverage of telehealth to include all modes of delivery, to require that cost sharing be no more than for in-person services, and to encourage payment parity for telehealth, in addition to other steps to remove barriers to coverage of telehealth. To date, the implementation of this, we believe, has gone reasonably well. All of our domestic health insurers have taken a number of steps to expand telehealth coverage, and we've seen a dramatic increase in the number of telehealth claims that insurers are paying for and the reimbursement amounts. We understand that all insurers in Oregon's individual and small group markets, at least, have instituted pay parity for telehealth. And then in June, to try to create a little more certainty going forward about coverage of telehealth, the governor announced a voluntary agreement with health insurers that would continue all of these expanded coverages and payment parity through at least the end of 2020. And of course, the end of 2020 is coming up pretty soon. So that is part of why we want to get feedback from all of you, is to hear your thoughts about possible next steps with that agreement. So the next steps that we at DCBS are particularly interested in getting feedback on are, first of all, the current voluntary agreement, whether that may need to be extended or modified, and then whether we should consider more permanent changes to telehealth policy going forward, even after the end of the pandemic, so we can support appropriate use and coverage of telehealth. And then finally, something that we have been thinking a lot about is the interaction between our state requirements and federal requirements. As many of you know, the federal government has loosened HIPAA requirements around privacy and data security during the pandemic for telehealth purposes. We do not know when or if those requirements may change or go back into effect. Also, Medicare has loosened up its quite restrictive requirements for telehealth, and we do not know, again, whether that may change or go back to the way it was before, or when. And so we're trying to make some decisions in the dark, in a sense, about what might happen federally. So anyone who has any thoughts about what we should be thinking about given the uncertainty, that would be very much appreciated. Like I said, this is the first of a series of listening sessions. The next one is this Friday, and it's intended to get feedback from health insurance companies. And everyone is invited to attend, but that's the stakeholder we're hoping to get feedback from. And then there will be another one for consumers after the Thanksgiving holiday break on December 5th, which, yes, is a Saturday. The idea is to get folks who might not be able to attend if it was during a work day. And we hope we'll get some good participation in that as well. So with that, I will turn things over to my colleague, Katie Button from the Oregon Health Insurance Marketplace. Katie, are you on?
I am. Thank you so much, Jesse. Hi, everyone. My name is Katie Button. I'm the Plan Management Analyst for the Oregon Health Insurance Marketplace. And what that means is that I certify the plans we sell on healthcare.gov. Jesse, could you go to the next slide, please? Thank you. So we have our own window shopping display that you can find at our website, oregonhealthcare.gov/window shop. And it mimics the anonymous browse functions of healthcare.gov, where you can put in some information about your household and find out what plans are offered in your area and whether you might be eligible for tax credits or cost sharing reductions. Next slide, please. So this year, one of the things that we added to this plan display was telehealth benefits. So those are available in all individual market plans, but unfortunately that information is not displayed on healthcare.gov. So we did include it in our site so that consumers can see those benefits. And there are other benefits that are not available on healthcare.gov that we also display on our site. Next slide, please. So this slide is kind of busy, but this is just an example of where the telehealth is. You can see it's listed there at the bottom of the section under doctor's visits. All of our carriers cover it in a little bit different way. So this way consumers are able to see what the charge might be if there is one and any limits and exclusions. Next slide, please. And then because it is open enrollment, I must get our information out there. So that top link is just our main website, oregonhealthcare.gov. You can get easily to the window shopping site from there and a bunch of other helpful information. The second link, oregonhealthcare.gov/gethelp, is where folks can find free local help in the form of insurance agents or community partners that can help them choose the right plan for them and also help them with the Oregon Health Plan. And then finally, at the bottom is healthcare.gov. You cannot enroll through oregonhealthcare.gov. You do need to go to healthcare.gov to actually enroll. So that is that, quick and dirty. Thank you so much, Jesse.
Great, thank you, Katie. So our next presenter is Trilby DeYoung of OHA. We're having a little bit of technical difficulties, I think, getting her unmuted. Trilby, are you there? So this is a product of our success in getting a lot of people on the call, and we appreciate having you all there, but we are having a little bit of technical difficulty with getting people to speak here, so bear with us for a minute.
Jesse, can you hear me?
Is that Amanda?
Yes, this is Amanda. Okay, so it looks like, yes, Trilby is not able to unmute. She was speaking, but we couldn't hear her. So just 1 second, let's see if we can get her on, and otherwise I can take on the presentation. So just one moment. Sally, are you able to hear us and able to get back to your functionality?
My functionality is interrupted continually with people trying to get in. I cannot find I cannot find Trilby's name anywhere in the list to try to unmute her.
She's just by phone. She's only here by phone because she wasn't able to get in by video.
Do you know her caller number?
Yeah, let me see if I can get her caller number. Sorry, everyone, just one moment.
Hey, Amanda, this is Ruby. You could have Trilby try *6 to unmute herself.
Ruby, thank you so much. That's excellent. Trilby, if you can hear
That
us.
worked for me. I just did it.
Yeah.
And it worked.
I just
Great.
hit star 6. I should have thought of that. Thank you, Ruby. That was
Thank you.
okay. Wow. All right. My apologies to everybody. My name is Trilby DeYoung, and I'm the Deputy Director of Health Policy and Analytics, which is one of the divisions within OHA. And at this point, we are coordinating within HPA the various efforts that we've been making on telehealth since the pandemic hit. So I'm just going to give you a brief survey of some of our data showing utilization and then what we've been doing on telehealth policy. So next slide, please, Jesse. And I cannot see your slides, but I'm going to assume that you're now looking at a utilization chart. And what I wanted to show, yeah, we're good? Okay, great. So as you can see from this slide, it's an incredibly dramatic uptick in our claims data in utilization of telehealth services. And the steepest climb comes directly following the governor's declaration of emergency on March 8th. And then, the utilization slows a bit gradually, but we are still in a place where we have dramatically higher rates of telehealth utilization, particularly in the CCOs, but also quite a bit higher in fee-for-service. So I think, it's clear that telehealth services have played a critical role during the pandemic in maintaining access to healthcare. Next slide, please. Okay, I'm going to assume you're on the next slide. I am frozen here. So I can't actually get my slides to advance. Okay, I see why. All right, here we go. Sorry. No. I seem to be having incredible technology problems right now. I don't know if my whole system, let's see, now. All right, Amanda, I might still have to ask you to take this over because my system seems to be freezing on me here. And I can't see
at all. No problem at all, Trilby. And that means feel free to stop me at any point if you get functionality again. So the slide that you have up here, and thanks so much. So the slide that everyone has up here, this is a slide of information from a recent primary care survey that the Larry Green Center has been conducting with primary care providers throughout the pandemic. While Trilby was just sharing, telehealth utilization, of course, has increased rapidly, and it's been essential to maintaining access. We also know that increased use has not been without challenges for all of you and for your patients. And when we looked at this recent data from the Larry Green Center, we noted that patients being unable to use telehealth was one of the most consistent stressors cited by organ participants. So we're really looking forward to hearing more from you all today about your successes and challenges with telehealth as we continue to plan for the future of telehealth in our state. Next slide, Jesse. So some of the concerns and barriers we've heard about from organ health plan members and community partners may actually help shed light on some of the challenges you may be experiencing on your end, and these are things you may have heard from your patients. But for example, we've heard strong concerns about barriers such as lack of access to technology or unfamiliarity with technology. These are especially acute for our houseless community members who, for example, may lack access to a phone or even a place to charge it. We also know that there are still significant gaps in internet access, especially in our rural communities, and access to high-speed broadband that might support video visits. We've also heard concerns about privacy and lack of access to a space for a telehealth visit, especially for certain groups like teens, people experiencing interpersonal violence. And we've heard about challenges accessing interpreters, cultural barriers to getting healthcare over the phone. For example, we've heard in some communities that it's just culturally inappropriate to speak with a provider over the phone or by video. OHA's 10-year goal currently is to eliminate health inequities, and building a telehealth system that works for all is part of that work. Next slide, Jesse. So throughout the pandemic, we've been really focused on the Oregon Health Plan rules and really trying to align flexibilities to ensure telehealth access. And in March, the Health Evidence Review Commission approved updates to its ancillary guidelines. There was another update in October, and these were used as a framework for temporary emergency rules, and now more recently, draft permanent rules that will be effective January 2021. Next slide. So just to note here, these general telehealth rules that are now open for comment, and we wanted to bring these to all of your attention. That today's listening session is separate from this rule feedback opportunity. And if you do want to provide formal comment on these rules, which are overarching telehealth rules for fee-for-service and also a rule for CCOs, then this is the process for providing comment. You would need to provide comment to the email hsd.rules@dhsoha.state.or.us. And I'll just say that again for those who are on the phone, hsd.rules@dhsoha.state.or.us. The public comment period is open through 5 p.m. This Saturday, November 21st, and final rules will then be filed with the Secretary of State office and effective again January 1st, 2021. Next slide. And then we just wanted to briefly mention OHA, the PEBB and OEBB, the Public Employees Benefit Board and the Oregon Educators Benefit Board are also under OHA. And just wanted to briefly mention some of the high-level changes that have been made amongst those plans, which are not standard throughout PEBB and OEBB. So Providence plans, for example, have been covering telehealth in full without member cost sharing when received from in-network providers, but there's out-of-network cost sharing for out-of-network providers. MODA, which is in both OEBB and PEBB, has been having telehealth services for primary care and urgent care covered in full without member cost sharing, when received from a network provider. Other telehealth services are covered with regular member cost sharing, including behavioral health. Kaiser is also covering telehealth services and really pretty broadly. The only services that are subject to member cost sharing are non-COVID telehealth services in members in high deductible health plans. And all of the plans are covering over a variety of platforms and including video and email, audio only. Providence and MODA in particular have increased provider reimbursement. Next slide. So these, we just wanted to leave you with some resources. And for those who are still joining the meeting, we are sharing some slides. If you're on the phone, you're obviously not seeing these slides. We are going to be collecting emails and providing these slides after the meeting. We're also looking for a place to post them. If you are calling in by phone, I want to make sure that we have your emails. So if you could put those into the chat to the organizer, then we can make sure we can get these slides out to you. So these are what are on the slides right now are just a list of the telehealth rules in various contexts. And then next slide. And these are a smattering of other telehealth resources that might be useful to you. The link to the Health Evidence Review Commission's prioritized list, the COVID-19 provider guide for Oregon Medicaid, which includes a telehealth section, a recent set of guidance particularly for community behavioral health services, and then a new toolkit that many may have seen for telemedicine for health equity. This is from the Center for Care Innovations. And with that, next slide, I think I'm passing this back to Jessie. And thank you so much again for Trilby for joining, and so sorry we had some technical difficulties.
Thank you, Amanda. You handled that beautifully and went through all those slides beautifully. I just want to apologize again to folks for the snafu. I'm looking forward to staying on the line and listening. I think The difficulties I experienced are just a small part of what you all are probably wrestling with every day and trying to talk with patients virtually. There's just so many places it can break down. So I really look forward to hearing the discussion today. Thank you.
Yes, this really does underscore how there can be some challenges with all of these technologies. And I think everybody has had some experience with that over the course of this unusual year, shall we say. So the next segment of this listening session is going to be some remarks from providers who we spoke with in advance. So we have a list, and each person will have about 4 minutes. I will have to time you, so please try to keep it brief. We do have a large number of people on the line, and it is, I recognize it is possible that some of these speakers may not have made it on the line for one reason or another, in which case we can certainly come back to them if they're able to get on the line later on or anything like that. So the first person on our list is Nick Powers from the Winding Waters Clinic. Nick, are you on the line?
I'm here. Can you hear me?
I can.
All right, thank you. I don't do this often, so forgive me if I stumble, but I really appreciate the chance to speak today and share our experience from way out here in Frontier Wallowa County. I'll say up front that I think it's essential that the OHA continue to support access to telehealth services. We've been providing telehealth services as a primary care organization and an organization that serves patients in inpatient hospital setting and in the emergency department. We've been doing telehealth for about 5 years now in various forms. It obviously picked up a lot with COVID, and it's been essential to our patients getting access to care. And we do suffer from broadband challenges and technology challenges in general, but we have a essential group of patients who really appreciate telehealth and otherwise wouldn't be able to come in for care because of transportation issues or the inability to get in during hours that we're open, even though we're open 7 to 7, Monday through Friday, 9 to 1 Saturday. People's schedules are hard. They live farther away over some pretty rugged mountain roads and through deep canyons. And so we've really seen it do amazing things for folks with transportation concerns in particular. 2 brief examples. One is about the icy mountain roads. There's an elderly patient just last week told her provider that, I guess I'll see you in the spring because the weather had come and there was no way they were going to drive over the icy roads in the winter. The provider was able to say, hey, are you comfortable with technology? Do you have an internet connection? Can we practice while you're in the exam room to make sure your mobile phone, for example, will work to get into a video visit? And they did that. And that patient now will be able to access chronic care management services and see their PCP for the whole winter, whereas before they just kind of quit. It was like they were a snowbird for healthcare because it was just too challenging to figure out how to get over to our clinic from where they live. And then the second patient on my mind is different provider shared a story with me about a teen who it's really hard times right now, right? And is trying to transition to college at Oregon State, major life transition anyway, plus COVID, is really struggling with a couple of health concerns, including their mental health and needing someone to talk to. And because this PCP has been taking care of the patient for the last dozen years, really since they were very young, and is a trusted person in this patient's life, they've been able to get care through that PCP and then also establish a relationship with one of our counselors here at the clinic and trust that person and be ready and willing to share with them. And I think that's a really different experience than what you could get on campus with new providers, right? And so what do I ask the state to consider as we move forward? I ask that you please support long-term healing relationships. Try to find ways to make sure these aren't one-offs that fracture care. Consider requiring in-person care at least once a year to be eligible for a telehealth payment for a patient. Consider requiring that any primary care delivered by telehealth be from a provider based in an Oregon PCPCH. That's a great model, the PCPCH model, that we should be building. It helps us move to value-based care. And then please support access. Don't have strict requirements about where a patient or a provider are located, as long as the provider's licensed in Oregon and the patient is somewhere in Oregon, right? And then please encourage or require commercial health plans to work with local telehealth providers to care for patients in their communities, so that especially our frontier communities don't get hollowed out and our providers left only doing urgent care, things where you have to lay hands on a person. We do good care across the board. We don't want to get stuck only doing urgent care because cheap telehealth is available from far away. Thank you for listening to my thoughts.
Thanks, Nick, and amazing job giving it to 4 minutes. That was almost exactly 4 minutes. So our next speaker, if you're available, is Amanda Wheeler-Kay, a healthcare interpreter.
Yes, I am here. Good afternoon. Hello all. Thank you so much for giving me the opportunity to be here. My name is Amanda Wheeler-Kay and I work as a healthcare interpreter, Spanish and English here in the Portland area, greater area. My comments today also incorporate the ideas of my colleague, Piawi Ringhinda, who's a Thai English interpreter. We just wanted to let you know that as interpreters, we have some experience in a variety of appointments, from things such as urgent care appointments, physical therapy post-hand surgery, and including an abortion, including conferences, and also wraparound service appointments as well that are not located in a clinic. Things that have gone well, a couple of speakers have mentioned already, access is huge. It's been wonderful for people to have access who have issues with transportation, who live far away from clinics, who have childcare issues right now. That's been really important. From an interpreter perspective, it's been wonderful not to have to calculate travel time to get to appointments. Most interpreters that are spoken language interpreters who are contracting here in Oregon do not get paid or reimbursed for their travel time nor for mileage. And so this has been significant. And of course, it's safer as interpreters. We're not having to be exposed to not just COVID, but other contagious illnesses. So those are benefits to telehealth. Some of the challenges that we have run into, in addition to some of them, the challenges that speakers have mentioned previously, such as the technology difficulties, it's an additional barrier for people who don't speak English. So the instructions perhaps are not available in their language for how to get onto a platform that they may not be familiar with. And a significant percentage of people that we work with haven't previously had experience accessing services remotely. And so there's been this learning curve in addition to just the actual, how do I get onto Zoom? How do I get onto telehealth platforms that my provider is using? Also, it's very different from accessing from a phone versus from a computer. And so there's been a couple of difficulties sometimes when the provider is seeing something from a computer and the patient is trying to access it from a cell phone, never mind getting online, etc. Another issue that we have had as interpreters is we mostly work as independent contractors for interpreting agencies, and our interpreting agencies don't always prioritize local interpreters. And so as you can imagine, as healthcare appointments dropped off, interpreters also had a reduction in our work. And if we don't have prioritization of local interpreters, that has a significant impact on our ability to keep working as interpreters and can have larger consequences down the line. And finally, pay has been an issue for us. In-person appointments, we generally get paid for 1 hour minimum as spoken language interpreters. And oftentimes for telehealth appointments, we're getting paid by the minute, depending on how long the appointment lasts, which is a significant reduction in our pay. So I would like to ask OHA for three things. The first thing is consider extending the idea of continuity to care also to interpreters. What Nick just said about not having it be kind of a one-off, we asked that too for interpreters. What does this look like? This looks like considering requesting the same interpreters. If you've had interpreters that had a good experience with a patient, oftentimes patients establish relationships with interpreters, and it does have a positive impact on their care. Conversely, they might have a problem with an interpreter, so it's very important for clinics and clinicians and insurance care providers to be educating patients on what their rights are related to interpreters and access to interpreters and rights to file complaints. Second, we urge OHA to prioritize working with local interpreters, very important. And finally, I request that Oregon Health Authority recognize and challenge the power imbalances that are inherent in the clinician experience. By and large, non-English speaking patients and interpreters, not myself included, but are largely immigrants and refugees and people of color, and do not have a voice at the table for determining, making decisions that directly impact their health and well-being. So I urge you all to be allies in providing meaningful opportunities for their voices at those tables to make those decisions. Thank you so much for your time.
Thank you. And our next presenter is Ruth Zuniga, who's a licensed psychologist and associate professor at Pacific University. Are you available?
Yes, I'm here. Can you hear me?
We can hear you.
Thank you. So as Jessica was saying, my name is Ruth Zuniga, and I'm a licensed psychologist, but I'm also a clinical supervisor of a mental health clinic in Hillsborough. And so much of my work in regards to behavioral health and what I want to advocate today is for my work in regards to serving underserved Latinx and Spanish-speaking individuals who have limited access to cultural linguistic behavioral health care in Oregon. And so telehealth actually has opened new opportunities for service for many Latinos and Latinx people, especially in rural Oregon. And suddenly we were blessed to start being able to have opportunity to provide services to our patients in rural areas and not only in the Portland metro area. However, that also brought a new challenge, which it is as more clients and more patients ask for mental health services that were culturally incongruent and linguistically appropriate, we have also the difficulties of meeting that demand. And that is one of the things that with telehealth, it has opened opportunities, but also it has highlighted already some of the inequalities and inequities that exist within the healthcare system. And so one of the things that will be important to share is that it has been really nice is to have the opportunity to get to offer audio telephone only services versus video services. And this is not only because of the lack of reliable internet to our communities, but also the lack of technology, as the speakers or the presenters were mentioning before, but also sometimes is a sense of comfortability, how comfortable many patients may feel in regards to being on video versus on phone, and also lack of privacy. I can share stories and stories about mothers who may have several children at home, and the only way that they can receive a little bit of mental, emotional support is by going for a walk on their phone and not necessarily using a smartphone. Another thing is I have several experiences, but one experience that I like to highlight is recently we have a patient that received a smartphone that we thought that with that we will be able to have video phones or video conference sessions, but actually through everything that we tried, we will not be able to help that person to navigate the system. So even us supporting the client or supporting the person, there was no services available that could help that person learn or navigate the challenges of the technology. And not only because not having the ability to understand of the technology, but also because much of the technology, it is in English. And so, as I was mentioning, it's just the barriers have been highlighted and the opportunities has been also highlighted within healthcare. But I think if I want to encourage the Oregon Health Authority or Oregon to continue supporting us telephone audio opportunities, also understanding that culturally informed care and also linguistically appropriate care is part of the practices and the guidelines of telehealth, and that appropriate training are also provided to providers as many providers not only may not have the training to do the telehealth care, but also the training to do telehealth in a way that is culturally informed. So thank you for listening. And 4 minutes went very fast.
It tends to do that. Thank you so much. So our next presenter is Amy Mulcaster of the Portland Clinic. Are you on the line?
Good afternoon, I'm here. Can you hear me?
We can, thank you.
So I'm Amy Mulcaster, and I am an OBGYN by training. I've worked with the Portland Clinic for the last 12 years as a practicing gynecologist, and recently took the position of the Chief Medical Officer for our organization on April 1st. Just for those of you that don't know, Portland Clinic is 100 years old next year. We're a locally owned practice, multi-specialty practice owned by 40 doctors who practice at the clinic, and we employ 60 other providers and 400 staff members. We are consistently recognized for our patient satisfaction and our good access and affordable cost of service. In February, at the time of when everything kind of came crashing down, and then in March, we had we were not involved in video or telehealth at all. No video visits, very little phone service for medical needs. But in April, we were able to serve approximately 12,000 patients through our telehealth program, which represented about 2/3 of our service delivery at that time. I know the other speakers have talked about examples that really shine through as far as access. I can tell you myself personally, as a gynecologist and seeing patients for the last decade here, it has really opened up access for patients that can't necessarily bring in family members to the clinic because of the pandemics and some of the restrictions that we've had. I had a patient early on in the pandemic who had a baby and was struggling with postpartum depression about 7 weeks after her delivery. And she had a newborn at home and a 2-year-old. And to be able to offer her telehealth video visit was really helpful. She actually did her video visit from the car with the kids in the back, just for some privacy from her other family members in the home. So super important for that type of patient. For us in the last couple of months, telehealth is still representing about 10% of our service delivery. And so we would like to ask OHA to continue to support telehealth. For us to continue to offer telehealth to our patient population, there are 3 things we'd like you to consider. The first one is considering continuing reimbursement for video and telephone visits at the same rate as in-person visits. The reason for this is because most of our healthcare service involves people who are paid for time, not just provider time, but our time for our staff, our MA support, our nursing staff, our business office personnel, and this is all incorporated in the time we take to deliver the care to our patients. These same services need to be paid for regardless of the point of service delivery, whether it's in person or telemedicine. And so in order for us to provide that, we need to make investments in our IT services to support all of this, including our medical records, our computers and audio capabilities, etc. The second thing is that we can provide telehealth safely and securely with IT security if it's offered through our electronic medical record system. And we really want to continue to allow that opportunity, again, because it really speaks to our accessibility for our patients. At this point, I feel like our patients are really expecting that this is an option for them. A lot of them are really nervous about coming into the clinic for various reasons, chronic illnesses. And so they are greatly relieved to know that we can still continue to care for them in a satisfactory manner using a video or a telephone visit. And then lastly, the third important point I want to share is that healthcare really for us is a local experience. And it would be really unfortunate for us to not be able to provide this, because if patients do expect this service and they look outside of Oregon and maybe at a more, a remote service to provide telehealth, they would be lacking the follow-up. So we have, a strong a local patient base here that would appreciate that if they could have a telehealth video visit or phone visit with their provider, and that was determined that they didn't ultimately need to be seen, you already initiate that through the provider that you have trusted and had continuity of care with from the very beginning. So it's really important for us to offer this as a range of services to our patients. We have had so many patient experiences that have been positive through telehealth. Mental health is a big one. You know, as you all know, anxiety and mental health issues have been certainly escalated during the pandemic, and to offer patients that appreciate the security of their own home, but still able to reach their mental health providers in our clinics has been a really positive experience for them, and they're really grateful, and we want to continue that level of service to not only those patients, but all of the patients that rely on us for care. So we appreciate the time to share our opinion, and also to ask for your support for access to telehealth across the Metro Portland area.
Thank you so much. Our next speaker is Max Janicic. Are you available?
I am. Can you guys hear me okay?
We can.
Great. Hi, everybody. Max Janicic. I'm from One Community Health. We're a federally qualified health center that serves about 17,000 patients in Hood River County, Wasco, Klickitat, and Skamania. So we're kind of a border clinic. I'll start with what's gone well, because I thought that was kind of a nice start by the other speakers as well. Like Nick said, transportation, that's a huge deal, especially now with winter coming. Gorge gets very icy, dangerous, windy, for those of you who have driven in it. It definitely provides and has provided us a great window into the home. I think it's created this virtual home visit. You know, for instance, we had a patient that had suffered a stroke, and our provider was able to kind of walk through her home with her, with a family member guiding the visit, look at obstacles, look at the pill bottles, do the activities of daily living, and it created a whole different way of engaging. I think that was value added, and we see a lot of use cases like that. Certainly, I think it has tremendous potential for group visits, peer support, a lot more we can be doing in between visits to help our patients take more control over their health and get support from others who have been there with similar conditions or experiences. So I think it has almost a huge untapped potential there. You know, for us, it also helped us maintain continuity. We've had a lot of staff who have had to work from home, for instance, with you know, either family members that had health conditions or themselves that were at risk. And so for some of our providers, they've been able to maintain continuity of care with patients. While they might not be able to see them physically in the clinic, they're able to do it virtually, which is pretty awesome. And then obviously conserving things like PPE and other things as we are in another kind of rapid increase here. I think that really helps us be a little more judicious with some of those resources. Opportunity-wise, you know, I would also agree with Dr. Mulcaster on, we're in this moment where, you know, I do think we want to incent video, but there is this migration we're under, and I think that a lot of providers like ourselves, we need time to kind of get people over to video. When we started, I think we were at 28% video on 70% virtual visits, and now we're up to about 49% video, but our virtual visits have come down to about 23%. So, but we're getting more focus on video, but it takes time. There's a lot of barriers, as we saw in this webinar. You know, I think it's for us, it's supporting broadband would be huge. The more we can do that, and there's a lot of disparities in broadband. If you look at like the Pew research, I think whether you cut it by race, I think, you know, folks who identify as white are at about 79% broadband, Hispanic 61%, Black 66%. If you look at it by education, college grads 93% broadband, high school grads 59%. So some huge disparities there that we've got to get in front of so that we give everybody a chance here to overcome those obstacles. I would say consider it like a blitz effort on tech literacy, on access, kind of like how we're doing contact tracing. What if we had like a statewide geek squad or something? Education obviously needs this as well, so maybe there's a way to combine budgets or resources. The other big thing for us is we have seen great use of it in mental health, but we're still struggling with a lot of different populations and engaging with the right language. So I think help around destigmatizing support for mental health would be huge, and some statewide campaigns, maybe some design around the right language. So that's it for me.
Great, thank you. So especially since we have such a large number of people on the line, which again, we really appreciate, we wanted to make sure that we gave folks the opportunity to engage and provide information in a bunch of different ways. So we were hoping to do a poll through the chat function. We may do this more than once, but we thought we'd start now in the middle of the provider remarks so people could keep the conversation going there. Amanda, would you mind kicking that off?
Absolutely, and apologies to those who are on the phone and can't see the chat and participate in this way, but we will have, of course, ways to participate throughout the meeting as we get into the forum section. But I just put the question in the chat. We're just curious for those who are able to see the chat, if you could just chat in, as you listen to the speaker so far, what is one thing that is resonating with you that might be related to your own experience? And we'll just, I think, continue, feel free to chat. We might call out a few and then we'll continue on to the next speaker, but feel free to continue chatting those in. And we hear from Susan, continuity of care and increasing access. Great, these are all rolling in. So Glenda Wilson, we need to continue to offer these services to ensure access to patients for treatment. From Kira, creativity and breadth of approaches and solutions. From Michael, facilitating access and equity across the care continuum. Jennifer, telehealth has provided access to healthcare opportunities and innovations in healthcare. Lori, I'd like to hear from someone in dental, and we have someone on who will be sharing some experience and possibly others who are participating as well. We also, accessibility, maintaining care, particularly for mental health, and telehealth needs to be standard of care, and video and telephone equally important. So a lot more are coming in. There's a ton of response here, so thank you all for chatting those in. I'll turn it back to you, Jesse, though, so we can continue with our prepared remarks.
Thanks, Amanda, and please keep the chats coming. So our next speaker is Jonathan Soffer from the Mid-Columbia Medical Center. Are you available?
Yeah, can you hear me okay?
Yep, go right ahead.
So my name is John Soffer. I'm a nurse practitioner at Mid-Columbia Medical Center in the Dalles. I'm also the medical director of the internal medicine service line. We're, of course, neighbors with One Community Health, so we're the 43-bed hospital in the Dalles, and we serve largely the same region as One Community Health. Overall, telehealth has been a huge boon to our practice, like it has been for most rural health practices. Many of the positive experiences that I was going to talk about, I think, have unsurprisingly been echoed by everyone else who's been on here so far, which I'm happy about. I think in particular, our experience reaching those with mental health needs has been very, very good improvement that we've seen in our clinical practice with the implementation of telehealth. And I've also been heartened to see how much more we can reach our elderly population that is often isolated and does not drive. Even the ability to just do a telephone visit versus a telemedicine visit has been really, really helpful in connecting with our elderly population and getting insight into their home life and maintaining continuity of care. We care for a lot of patients in facilities at our practice. So those are like assisted livings, nursing homes, other similar practices, or other adult foster care. And the ability to implement telemedicine to reach those patients, particularly during the time when those facilities have been locked down or quarantined, has not been good. It has been essential. There's been no other way to care for that population without using telemedicine. And I have no idea what we would have used if telemedicine wasn't an option. I think that we've seen some other kind of business level positives. For example, our amount of no-shows for our appointments have plummeted. It's very difficult to no-show from your phone, particularly if you're in your own home. And then for us, a huge improvement given our rural location has been the accessibility to tertiary care center specialists, for example, OHSU, Oregon Clinic, practices like that. Whereas, historically our patients either are very unwilling or are unable to transport themselves to the Portland metro area. The ability to have a telemedicine or a telephone consult with a specialist from the comfort of their own home oftentimes has been truly invaluable to us. I think, as far as positives, that's a lot of them. Two other things that I just wanted to point out that one hasn't been mentioned here. Of course, our region, like other regions of Oregon, have not been immune to a lot of the natural disasters and climate changes that have happened recently, particularly the fires this summer. Although we were seeing in-person visits during the fires this summer, due to how severely they affected the air quality in our area, we were able to convert to 100% telemedicine overnight to serve our population again, because we already had that in place due to the pandemic. And I'm sure that this was probably echoed elsewhere. And I think the reality is our practices have to have a structure to be nimble, to adapt to changes in regional climate, changes in natural disasters, stuff like the pandemic. And telehealth being in place kept us going during that time, and I'm very grateful for that. The only downside that we've experienced in our specific practice is, as a rural health clinic, we receive special rural health clinic reimbursement flat rate from Medicare. That flat rate is only for in-person visits and does not match the telehealth reimbursement, although that's of course not a state level determination. That's been extremely difficult for us financially, because in our particular practice, the majority of our patients are Medicare patients. So we're hoping that the federal government, of course, along with OHA and the Oregon state government, continues to take an aggressive approach to not only implementing telemedicine and telehealth, but growing it and seeing it as an equal to in-person care, because I think it's been excellent for us. That's it for me.
Great, thank you. So our next speaker is Caitlin Margatan. Sorry if I'm butchering the name, from Cascadia Behavioral Health. Are you available?
Yes, can you hear me?
I can.
Great. As Jesse said, my name is Caitlin Margatan. I'm a psychiatric nurse practitioner and site medical director for Plaza Recovery and DCJ Community Services at Cascadia Behavioral Health. My area of focus are adult outpatient and forensic psychiatry. Cascadia is one of the largest providers of community-based behavioral health and substance use treatment in Oregon. We serve about 18,000 individuals a year across services in health centers, residential programs, crisis programs, street outreach, and criminal justice programs. And then for us, the way we started about in February, recognizing that to keep these diverse programs running in the context of the growing COVID-19 crisis, that telehealth was going to be key. We didn't have any telehealth programming in place prior to the crisis, so to facilitate a smooth transition and identify protocols for ongoing in-person services, we developed an incident command center. And that has been really helpful in getting folks together and talking through what's going well and what's not. In a matter of about 2 weeks, we converted about 80% of our outpatient services to telehealth via phone and video. The primary issue we have observed and concern we would like the state to consider is that we have seen inequity in access to technology, as many of you have already said. Specifically in our population, we are working with folks that are lower income and a high minority population. And a lot of our folks don't have access to a cell phone, much less internet. So to prevent these persons from being cut off from care, it is important to find ways to facilitate improved access. Some of the ways we have tried to do this as Cascadia is to maintain a small rotating crew of in-person teams. We've also distributed iPads to community-based teams so they can aid clients in connecting to other service providers in the community. And then we've developed on-site portals for clients to come in and use our resources to connect virtually to their providers, and that's been really helpful. However, difficulties remain for clients to access these services, which connects to our second concern that we'd like to share with the state. So we'd like increased guidelines for when to use telephonic versus video engagement, because so many of our folks only have that phone resource, and finding ways to blend those platforms would be really helpful. Some of what we have done is finding ways at minimum to do that initial assessment over video, and then connecting clients to labs and nurses to get their vital signs done. Finally, we'd like some aid for both clients and for providers in the financial and technology literacy spectrum. As many of folks have said, troubleshooting those individual technology issues is really difficult, and produced need to ask clients to come in person, or switching from video to phone in the middle of appointment because someone's muted and we can't figure out how to unmute them, just as we saw at the beginning of this presentation. And those are my main things I'd like to share. Thank you.
Great, thank you. So our next speaker is Mandy McKimmey from Cascade AIDS Project and Prism Health. Are you available?
I'm here. Can you hear me?
Yes.
Hi, good afternoon. My name is Mandy McKimmey. I use she, her, hers pronouns, and I'm the medical director and a primary care provider at Prism Health, which is in Portland, Oregon. Our clinic is a safety net clinic, and this past March, we became deemed a federally qualified healthcare center lookalike. Our primary focus is serving LGBTQ patients for primary care services. We offer a lot of HIV prevention, HIV treatment, and gender-affirming care as well. And this past year, despite COVID, our clinic has really grown. We've got 5 full-time medical providers now and 3 full-time behavioral health providers whose panels are all completely maxed out on the behavioral health side. If that kind of paints a picture for the need for behavioral health in our patient population. We really freaked out when COVID hit because we do care for so many patients living with HIV, and the original data and information that was kind of spread was really mixed on how to take care of people with HIV and if they were at more high risk or not. So we actually switched to telehealth within about 72 hours in mid-March. We lost 2 days of patient care while we did that because we had to train our providers and train our staff. And we had to secure funding to purchase the part of our electronic health record that allowed us to have access to telehealth, confidentiality, and meet all the security standards that we needed to meet. So it happened pretty quickly, and everybody picked it up pretty fast. And we actually switched 100% to telehealth at that point. It was really important for us because we serve a lot of clients who are houseless, and a lot of our houseless clients are also living with HIV. We also have a very large population of transgender patients, most who are on OHP, and most of them have very limited resources and are also often our houseless population or patients who kind of couch surf or jump from place to place. And so being able to do telephonic visits has actually been really, really important for us. And, a lot of people who have a phone don't necessarily have the ability to figure out the technical piece to do virtual visits, but they can do telephone visits just fine. And that's been so important for us with our HIV patients and with our houseless patients. I can't even stress how, I think John said, the connection has been great because people answer their phone. And so our no-show rate has also dropped significantly. People are connecting for their appointments or answering their phones. I also wanted to mention how important it is for the telephone visits because the internet connections can go bad during a virtual visit, or something else can happen where the video fails, or there's no audio but only video. And when those cases happen, we pick up the phone and call the patient, and we're able to complete the visit and then switch it to a telephone visit. On a personal note, this past week, we had a positive COVID exposure in our clinic, so we actually closed the doors to the clinic and switched everything back to 100% telehealth for this week, as we're waiting for COVID-19 results from some of our employees, and some of our providers need to have symptom resolution before they can come back to the clinic. And, you know, this allowed us to work remotely with no interruption to our patient care for medical or behavioral health, which is really, really important for our patients. And then as a side note, I'm also a professor for OHSU School of Nursing, and being able to use telehealth has allowed me to continue to precept nurse practitioner students remotely. It's greatly conserving our PPE. When we do that, our clinic has had a lot of difficulty in accessing and maintaining our PPE supply, and so telehealth has been a great way to help with that as well. So on behalf of Cascade AIDS Project and Prism Health, we're really asking for you to support to continue payment parity, not only for telehealth, but also for telephonic visits, because we feel like this is going to be vital in the future to continue to provide the services that we do. I can tell you that we did continue STI testing from March on, and people did continue to have sex and did continue to get sexually transmitted infections. And us being able to do visits online and treat patients was wonderful. I don't think we ended up with any gap in that service. We also continued to do HIV testing and had quite a few positive cases that we were able to immediately connect to care, immediately connect to medications. So we would just ask that you continue to support payment parity for telehealth and telephone visits, and that patients and providers be allowed to be remote within the state of Oregon. That's really important for us, especially as a little tiny clinic. If we have someone get sick or more than one person gets sick, we're able to immediately switch to working from home and continue our care for our patients without interruption. Thank you for your time.
Thank you. Our next speaker is Sherry Ludwig of Advantage Dental. Are you available?
Yes, I'm here. Thanks.
Great.
So, hi, I'm Sherry Ludwig. I'm the Director of Clinical Innovation for Advantage Dental, and I am I'm a hygienist by background. And over the past 2 years, my experience with my work through Advantage has been focused on development and deployment of asynchronous and synchronous teledentistry as a dental care organization, but also overseeing the work within our 59 staffed model practices as a tool to help connect and maintain continuity of care. Again, a lot of the things that I will say are similar to those that have previously spoken, but I kind of want to highlight some nuances, I think specific to dentistry. Some things I think that have gone really well is that with the deployment, we focused at the systems level on trying to identify efficiencies that telehealth supports for that continuity and patient care. And it's been positive to have the flexibility within clinical workflows and implementation of this communication tool within our patients. And it's helped us learn, I think, from a systems, patient, and provider lens, most importantly. And it has allowed us the ability to engage patients and establish relationships outside of the dental practice. If you look at research, the #1 reason that outside of coverage of why folks don't access dental care has to do with fear. So with the use of telehealth, it has kind of bridged a gap for patients that may not have been non-utilizing the dental system to establish a relationship with those who they may be seeing within our practice. Some challenges that we faced, again, dentistry is something that is traditionally seen as something that's done to you, not with you. So changing the view of patients and providers to the environment that they've been conditioned to is a challenge. Again, dentists are used to, I think it's easier in regards to working with dental hygienists in establishing that relationship and the interaction they have. Dentists are, surgeons, and that's kind of, I think the feedback that I've seen is them trying to step into that role and really establish those relationships and focus on that behavior change and identifying what they can do through telehealth. Since it's so hands-on and technical. Billing, I think that for the overall, just given our payment structure within our organization, has been fairly straightforward. I think that, again, to speak to what the others have presented, the need to have the continued support and access for telehealth and payment parity for those various telehealth modalities, and to account for the various needs and technology available to consumers of the healthcare is imperative. I keep going back to think about the Institute for Healthcare Improvement and how they are focusing on, how do we get the care to the patient where they want it, when they want it, and how they want it. And so making sure that we've got, the policies and reimbursement to help support the consumers. But sometimes within like that reimbursement, the paperwork and that needs to be in place to allow for payment, having the technology account for that has been a struggle. Broadband strength, again, we take care of well over 300,000 lives in rural and frontier Oregon, and the technology works for the dentist, but not necessarily at the member level. And so trying to identify ways to bridge that gap for those consumers utilizing the platform. And then I just want to reiterate the need for ensuring culturally appropriate and accessing the platform for, those individuals that aren't able to read or it's not in their native language, how do you communicate that to them to how to access the system if they're unable to come in person for, the example of when that patient was in the practicing, going through them, like how do we make sure that we're able to communicate for all the learning styles to have equitable and appropriate care. And I guess the last thing that I just want to reinforce is I think the need for that tech literacy campaign would be huge, and learning from the consumers on how we can modify the healthcare done through telehealth to meet their needs and help increase their level of awareness of what telehealth means through behavioral, oral, and physical health.
Great, thank you. So our next speaker is Jennifer Stahl from Ochin.
Hi, can you hear me?
I can.
Thanks, Jesse. And thank you to DCBS and OHA for conducting this important stakeholder outreach on telehealth. And for those of you that may not know who Ochin is, we're a nonprofit Oregon-based health IT organization. We work with 34 unique healthcare organizations across the state in Oregon and hundreds nationally. During COVID, we trained and helped health centers all over the nation, and specifically many here in Oregon implement telehealth workflows, telehealth technology platforms, making sure they have medical grade broadband, and et cetera. And we were lucky enough to be one of the recipients of the FCC's telehealth grants. We received a $2 million grant. Many of those dollars are going to Oregon health centers to help close some of the health equity gaps driven by not having access to technology or broadband. We also pull in millions of dollars to the FCC's Rural Healthcare Fund to be able to make broadband affordable for healthcare institutions across the state of Oregon, which is really, really important as we're trying to close the gaps in terms of broadband and connectivity, which you've heard about today. So as a data company, I wanted to give you a few statistics of what we're seeing across the network of health centers that we support in Oregon. Which includes, we've seen over 900,000 telehealth encounters year to date in Oregon, representing about 28% of all visits in the OCHN network. This is pretty significant. It's been steady at about 28 to 30% for the several last months. So we're seeing innovation is definitely here to stay. And 50% of all behavioral health visits in the OCHN network are also virtual, with really strong patient satisfaction in behavioral health. So one of the things that we wanted to make sure that we spoke about today is encouraging OHA and DCBS to ensure that payment parity for these services remain, that the restrictions that allowed health centers to deliver telehealth that were removed during the public health emergency, such as geographic restrictions and distance sites, that they become permanent in state statute as well, and then and make sure that there's continuing access for patients, especially those in being served by OHA, because I think Nick Powers spoke about this earlier, making sure that health centers can reach the patients where they best are served. And we continue to have telephonic services covered as last resort for patients, especially those that may be underserved. So with that, I will pass it back to you, Jesse, and thank you for the time.
Great, thank you. So we have one more speaker, and then we're going to open it up. And this last speaker, Michael Olson, requested that we share a document. So I'm going to, so bear with me, I'm going to unshare my screen and then share it again with that document. But Mr. Olson, if you could get started while I'm doing that, we'd appreciate it.
Yeah, thank you very much, Jesse. Can everyone hear me? Excellent. My name is Mike Olson, and I am part of Praxis Health. I'm a regional administrator in our Salem region. My background is as a physical therapist, and also as a father of a 5-year-old who's navigating kindergarten in this remote world, and also has some medical complexities that, we have visits with neurologists and hematologists and his allergist. It's been, from the patient and family member experience, it's been invaluable to have the ability with these regular visits to have the same conversation that we would have in office, protect our family and our community, and be able to manage, his health through telehealth. So I wanted to just share that as a personal experience that our family has had. Additionally, I think everything that the people have discussed, we've experienced here with Praxis Health, and I thought I would just give a real quick overview for the group, much as Dr. Mulcaster had shared with Portland Clinic. In March, we didn't have telehealth, and starting and since March, we have had, we've done 40,000 telehealth visits across our region. We do serve over 60,000 primary care patients across the state. We have over 250 providers, with about 100 of those as primary care providers, and 32 clinics across 10 different counties in the state. So, some of the discussion and points made around access and equity, certainly in Umatilla and Union County, even here in Marion Polk County, where I sit, we have seen the ability for access and equity to be much improved along the way as well. I think we're experiencing the same challenges. I think Amanda, kicking things off today, had some really great points. Our providers are feeling those same challenges and pain points in terms of implementing, sustaining, ensuring that our patients have that access. I think Nick and Amanda Wheely and Ruth, each of everyone's points we've certainly experienced. Did want to kind of talk much kind of on the positive. What have we seen as positives? We have seen that improved access, and really across all of our markets. Central Oregon, Northeastern Oregon, Portland, Eugene, here in Salem. And we've also been able to really leverage partnerships with our specialists within our network. Here locally in Salem, we have behavioral health services through our psychologists and psychologists over in Central Oregon, which has helped with access issues that our patients have had to those services of behavioral health. I think that was brought up by a couple of different groups today. We've also been able to have neurologists service and do same-day appointments for consults. So that has created a really great point of access for our patients. We've also seen, the ability to maintain patient-centeredness around this and really look at, the ability to adapt. And as we continue to evolve in our care models, I think we can all recognize that telehealth is going to be critically important to that, as it has been throughout our experience in the global pandemic. Overall, though, the keys for sustainability, if we think about, COVID and a global pandemic, certainly was a tipping point for a need, but really what made it able to happen within Praxis Health was the ability of the emergency rules that allowed that pay parity. That truly made it economically viable for us to also be able to do. Not only is it the right thing to do during these times, but it's critically important. I think it's been pointed out that the same care that we're providing virtually still requires staffing. The buildings, we still have a large percentage of in-office visits, and that's going to continue to be the case. And the labor costs, the infrastructure costs are still there. And in fact, some of those went up as we, implemented, new technology and new services. So, that ability to have that continued pay parity is important. We also see, open market negotiations as an important component. And then, we will still, continue within kind of the quadruple aim. We have to continue to meet that patient-centered and quality-driven focuses. So, and Jesse, I don't know if you're able to scroll down. I thought something unique that we've been doing recently, but kind of here on second page, we've actually been doing some surveying of our telehealth patients over the last 3 or 4 months. And we have actually had 1,418 patients respond regarding their experience. I think we had 14 questions that they answered, but I just wanted to highlight 5 of them here, because I feel like as we talk about, what is there parity in the experience, parity in the quality of care we're able to provide. I think we're hearing from our patients that yes, and I think this first one, 91.6%, which I think was 1,387 respondents out of the 1,418, agreed or strongly agreed that the appointment was thorough and adequately met their needs.
I hate to interrupt, but we're going to have to move on pretty quickly here. If you could try to wrap it up.
Totally. Yep. And you can see the other ones here, in regards to the felt like appropriate time spent with them, and overall impression of the quality of their primary care provider was very high or high. So we're hearing from patients that there is that parity within care. So we certainly, much as others have requested, maintaining and advancing our ability to grow within telehealth. So thank you much.
Thank you, and thanks to all of our speakers. That was really great. Everybody did a good job with the time, and we should have some time for an open forum now. Bear with me, I'm going to pull up the slideshow again. And so now we are going to try to have as open of a discussion as we can, but given that we do have a large number of people, we want to make sure that we don't create a mess where we have a lot of feedback or people talking over each other. So we're hoping we can establish a queue for speaking. Amanda, did you want to speak to that?
Yes, so we are going to start here, since those who are on the phone haven't been able to engage in the chat so far. We're going to start here with those on the phone. And what we're going to be doing is asking you all just generally for your comments and feedback at this point, responding if you can just generally to this one question of what is one thing you want to be sure we consider as we move forward with telehealth as a state. And so for those who would like to provide feedback, if those on the phone, are you able to, oh, actually *6 I think is the way we can do this. So for those who are calling in, if you can *6 your phone and unmute yourself to let us know, first of all, that you'd like to provide comment, we're going to set up a list. I'm going to do the same thing with those on the chat. If you can just, while we're getting the phone, can you put your name into the chat if you'd like to provide comment, and then we'll just run down the list and get people engaged. So those on the phone, anybody would you like to provide additional comment? And please just do *6 to unmute yourself. So I'll pause for a moment here. But as we're doing this and seeing who would like to give additional comment on the phone, please feel free on the chat for those who are online. Please put your name in the chat if you'd like to give comment. It sounds like someone's unmuted and would like to put your name in. If you can just share your name for whoever's unmuted yourself, that would be great. So I'm not hearing anything. I see at least one person on the chat. Thank you, Carol. Anybody on the phone? Okay, well, this may be more straightforward then, and maybe many of you have been able to engage so far, which is great. So on the chat, we have a couple coming in. I'm just going to give another 30 seconds or so if you'd like to put your name in the queue in the chat. And as we're waiting here, for those who are on the chat, I'm just going to put this question in. But really, we're just generally looking for your additional feedback. Okay, so we've got a few more. Sophia. Okay, why don't we go ahead and get started here and turn it over to Carol. Are you able to unmute yourself?
Yes, can you hear me?
Yep, absolutely. Go ahead.
Hi, thank you. Thank you for hosting this. I am a.
Excuse me. Sorry. This is Jesse O'Brien. With these comments, we're also going to keep it to 4 minutes. If there was a larger number, I'd say an even smaller number of minutes, but I think we can manage 4. So just keep that in mind. Thanks.
Thank you, Jesse.
So I'm Carol Criswell, and I'm a manager of a Family Navigator program at Providence, which is a peer wellness specialist with the family support focus. We're traditional health workers who are billing for our services. What I would like to see is really tech support for supporting the billing process for telehealth broadly for different types of providers. Most of our service now, obviously, like everyone, it has to be on the phone. We don't have video capability at this point. But even in typical times, a lot of our follow-up, robust follow-up, is on the phone. And not billing is a value gap for this rich service. So it seems like there's a great opportunity now to look at billing for other support services for patients, but the tech support would be really helpful to be able to implement that in our own systems.
Thank you so much, Carol. And how about Lisa Lyons?
Hi there, can you hear me okay?
We can.
Thank you for this just it is wonderful to have such shared interest. My comments are that I manage for pediatric rehabilitation, speech PT, OT, serving babies through age 17, as well as physician specialists. And the ability to have telehealth has been a game changer for families. And it has allowed them to continue to have access to their skilled care and not have wonderful gains made be lost with how long the pandemic has extended. So I just wanted to say thank you, and I hope that it can continue for those families that need it.
Thank you so much. Now we have Sophia Wilkes from Outside In Clinic.
Hi all, can everybody hear me?
Yes, we can, thank you.
Thanks. So my name is Sophia. I'm the Quality Improvement Manager at Outside In, federally qualified health center with sites in downtown Portland, East Multnomah County, Clackamas, and Milwaukee. Thank you again for making the time and space for this session, hearing the voices of providers and health centers, as well as our patients and clients. We all know that the global healthcare landscape is shifting and has shifted to incorporate virtual and technological approaches to improve patient adherence to care plans, increase access and affordability, and to reduce infection risk, not just during COVID pandemic or the emergency declaration in response to it. Regardless of whether state or federal agencies declared an emergency, providers and health centers, especially serving the safety net, provide care every day to patients and clients who struggle to arrive for that care. Telehealth is a benefit for most patients, including those from rural areas, patients who struggle or cannot afford the basic costs of an in-person visit, that's transit and healthcare, time away from work, and patients with chronic conditions or who are immunocompromised, immunosuppressed, or those who otherwise struggle with mobility in a world not built for their bodies. A study published in Health Affairs in September of this year used a somewhat conservative model to forecast a variety of scenarios, and they estimated that primary care practices will lose more than $65,000 per full-time physician. That's $325,000 for a typical 5-person practice from fee-for-service payments without mitigation. So even assuming that those practices quickly pivoted to providing telemedicine services to make up in part for those losses, it's unlikely that some of those practices were able to make that pivot quickly. Notably, that loss balloons substantially if telemedicine payment rates revert to pre-COVID-19 levels. So independent and smaller practices were found in that study to be particularly hard hit, including their sensitivity analyses. And it's notable that hospital systems and hospital-owned practices experienced greater relief after the recent legislation. Those results imply that the federal subsidies are unlikely to be sufficient to ensure the financial viability of primary care practices. Of course, this has an increased impact on rural and safety net providers. Even after COVID-19 recedes, healthcare providers in the US will continue facing challenges of caring for the 100 million or more adults with diabetes or prediabetes and hundreds of millions with other chronic conditions, particularly given the fact that more than 60% of those visits nationally for such chronic conditions were delivered in the primary care setting. And the Green Center reported that 81% of practices have limited wellness and chronic care visits this year. We know that delayed care is a liability. So speaking on behalf of Outside In, we have seen our patients and clients on site using virtual technologies to reduce risk of infection. We've seen them remotely using telehealth and in-person as clinically indicated or as indicated by a patient's circumstance and access to resources. We are part of the nation's largest primary care network and have been on the front lines of the COVID-19 pandemic. In March, we quickly transitioned to virtual visits as best we could to keep our patients and staff safe. At points in the last few months, we have conducted up to 75% of our visits virtually using telemedicine and transformed how we are addressing patient needs. We've made those adjustments to care teams and staffing as the utilization for services decreased without access to face-to-face visits. Our patients have settled into a new norm, and we're still seeing sustained apprehension about returning to the clinic in person. Our visit rates have decreased to an average of about 70% of total capacity in our primary care services from pre-COVID-19 levels in the last 6 months. And I just wanted to close with Adrian Boise medical doctor, chief experience officer at Cleveland Clinic Health System, calls telemedicine, quote, empathy at an operational scale, defined as making life easier for patients, reducing suffering, and reducing time spent waiting. With skill and training in remote exam techniques, a practitioner can, and we do provide many health services remotely, still taking a thorough history and referring to specialists or conducting e-consults in real time. All of this to say, payment parity for telemedicine and structural support for telehealth administration is going to be tantamount for the survival of primary care, period. Thank you.
Thank you so much, Sophia. And now we have Matthew Hatch from Cascadia.
Hi, hello. My name is Matthew Hatch. I'm the Business Systems and Integrity Manager at Cascadia Behavioral Healthcare. My colleague Caitlin Margatan spoke earlier on some of our endeavors with telehealth since the pandemic started. One of the real benefits we've had with telehealth is through our residential programs, being able to utilize telehealth through iPads as well as the phone to prevent the spread of COVID by allowing clinicians to be able to work remotely and still maintain contact with residents at sites, and also being able to allow our residents to then connect with outside entities such as their primary care as well as family through these devices. It's been really beneficial for them. One of the things with telehealth that we would like the state to consider and is maintaining the telephone usage for services, even assessments for psychiatric assessments as well as a mental health assessment. We find that with our population, with a heavily SPMI population, as well as those experiencing chronic homelessness and economically disadvantaged, it is imperative that we have that route of access for them to be able to use a telephone to connect with services. Aside from that, we see some real potential with telehealth now outside of just using it for the pandemic, thinking about ways of continuity care between like an inpatient discharge and getting services with us, using telehealth means to prevent a patient from having to wait a couple of weeks to get into an appointment, being able to do something more on the spot through these means. So that's all I got to say.
Excellent. Thank you so much, Matthew. And we have Deborah Rumsey from Children's Health Alliance.
Hi, this is Deborah Rumsey. Can you hear me?
We can.
Great, thanks. This is Deborah Rumsey. I'm the Executive Director at the Children's Health Alliance, and we represent primary care pediatric practices and mostly the Portland metro area. And I just want to reiterate all of the positives that all of the speakers have said. They really did an excellent job of discussing how important telehealth has been to access for the patient population and maintaining that continuity of care. And so I guess I would like to just emphasize how important it is to maintain pay parity for telehealth services, whether they happen via video or perhaps in a step-down approach if video not available, access via telephone, because I think that it's really important that we don't leave out any buddy in the population to access services. We want to increase access. And I believe that providers can make important calls related to when it's right to bring that patient in. And a couple of things that I heard today that I think is really important. We really want to make sure whatever we do going forward maintains local care. It's really important to support this care. I'll say at the medical home, but really it's also within those specialists that have those established relationships. I don't think that we want all of our services going out to organizations that don't have that established relationship. So I believe that that is really important. I also think that it's really important not to leave out some critical services. What we've seen in the pediatric medical home as well as for our patients has been just the importance of access to behavioral health services during this time via telehealth. And not all services previously were accessible via a telehealth mode. And especially for me, looking at it from the pediatric population, this has been really a monumental change for the adolescent population, who actually feels more comfortable oftentimes accessing care through a telehealth mode than in person. And you might actually get a more open conversation in that mode because that's what their comfort zone is. And so I don't think we want to have any restrictions to that going forward. And so I think that, again, importance to stress, pay parity, keeping it local with that established provider. If we want to increase access to those that don't have access yet, perhaps more heavily weighted with the OHP or Medicaid population, perhaps there's opportunities to have that population be able to access services if they're accessing it for the first time. We don't want to restrict that, but I do want to keep it local. Thank you very much for listening to providers. I think this is a change that we're going to see going forward, and I'm really excited to see how it can continue to be a major part of care that we provide here in the state of Oregon.
Thank you very much, Deborah. We have a couple more that have come in through the chat. So Miles Ellenby from OHSU, would you like to speak?
Yes, thanks. Hi. I'll keep it brief. I'm Miles Ellenby. I'm a pediatric intensivist up at OHSU and have been the medical director for telehealth and now Office of Digital Health at the university. We've been involved in telehealth for 13, 14 years now, primarily initially for acute emergency care, but have expanded to, of course, ambulatory and remote patient monitoring like everyone else here. And just really want to second and third and fourth all the comments that people have made, that the epidemic or pandemic has really highlighted the promise of telehealth, but it has also, again, highlighted the disparities. And as we all know, healthcare tracks socioeconomics, as does broadband and device access. So while there was this great promise that telehealth would improve access to care, it is, again, highlighting access issues. One other quick comment regarding, I would often face questions about the quality of care delivered via telehealth. And I've always liked to remind people that it's just on the spectrum of how care can be delivered. And as long as providers recognize the limitations of the modality, good care can be delivered. Somebody once told me that you can deliver bad care in person or by phone or by text, just like you can with different modalities. So as long as the providers recognize the limitations, limited physical exams and so forth, quality care can be achieved. And one of the big powers of the modality is a triage tool, which others have highlighted. You can really identify those that do need to be seen in person and save that travel hassle for those that really don't. So thank you for hosting this. Really appreciate it.
Thank you so much. And how about Brandy Begin from Dornbecker?
Oh, hi, I'm Brandy Began. I'm the peritoneal dialysis manager from Dornbecker Children's Hospital. So we have a peritoneal dialysis program, which is the only one in the state of Oregon for children waiting for kidney transplants. The telehealth has been huge for our patient population, as we have patients all over the state of Oregon and Southwest Washington. So this has enabled the patients and their families to not have to travel 4 to 6 hours once a month to see us in clinic. Actually, I would say one of the downsides is now they don't want to come every few months to see us because they like the telehealth so much. So it's really improved access. We're able to communicate with them we use the WebEx platform. We're able to see inside their home, where the families aren't having to miss school, work, they don't have to leave their other children with family members overnight while they travel to Portland for monthly clinic. A few challenges that I think we've run into is that because we initially, when we had to move to telehealth in March, is that we do follow patients in Washington, and while our nursing staff is dual licensed in Washington and Oregon, we had to put in exceptions for our medical staff and our dietitian staff to be able to see our patients via telehealth in Southwest Washington. So I would encourage OHA to explore some of our neighboring states and maybe some collaboration moving forward, or allow that to continue for some of these patients that are accessing specialty services on either side of the state borders. The other problem that I see that we've run into is if we're having families as part of the ESRD dialysis billing, their labs are included in their monthly care that they receive from OHSU Dornbecker. And so some of the families have had a challenge having local labs drawn and getting bills for those. So I'm not sure that's more of an outpatient dialysis across the state issue if we're going to be using telehealth more. How do you have families or patients not have to drive to the facility? Another positive, we have multidisciplinary clinics, and so we don't all have to be in one clinic space at the same time. So we are able to have everybody on a WebEx meeting with the family and the patient. So that includes the dietitian, social worker, pediatric nephrologist, dialysis nurse, and the family. So that is another huge plus that we're all able to have a conversation together. And so I would just encourage you for the pediatric dialysis population and the home dialysis population in general to consider keeping telehealth available for this population. Thank you.
Thank you so much, Brandy. Now we have Monica Giammalaro.
Hi, thank you for the opportunity to speak. I just had 2 quick points. One is we just hope to continue pay parity as it is currently to include, both physician assistants as well as other advanced practice providers. And then secondly, just the concern has been raised by some of our organization's members who perhaps practice in the Portland area but live in Vancouver, that they're able to provide telehealth services from their home across state lines to Oregon residents. Thank you.
Thank you so much. And we have someone from the Oregon Society of Physician Assistants. I don't have your name. Would you like to speak?
Sorry, that was still me, Monica. I just hadn't included it in my first text. Thank you.
Thank you. Now I'm seeing that. Okay. Great. And we have Mike Franz. Dr. Franz, would you like to speak?
Sure. Yeah. Just I've been practicing telepsychiatry for over a decade, and really have been thrilled to see the increase in the use of telehealth services brought on, unfortunately, by COVID, but overall just thrilled about it. I just caution us in regards to quality of care and health equity concern using voice only. And I'm sorry I had to leave the meeting for a while, so there might have been some comments on this, but the health equity issue with voice only, from my perspective, is not that we got to just keep allowing voice only telehealth services for the BIPOC population or marginalized population that can access video. I actually see it the other way. I see why should our marginalized members be relegated to a lower quality of care for receiving telehealth by getting voice only services rather than synchronized video and audio, when we don't have any research to support that voice only is an effective, high quality way to render a variety of services. We do have that research for synchronized video. So instead of saying, hey, in perpetuity, let's just equate voice only with synchronized video, I would challenge us to figure out how we can connect our marginalized population to the platforms and systems and bandwidths that are needed to access what we know is a high quality service rendered via telehealth, and that's with synchronized video. So just like we have non-emergent medical transportation as a covered benefit on the Oregon Health Plan to get members to brick and mortar appointments, and we really need to be considering that same kind of coverage in this brave new world of telehealth so that we can get all members, all patients to their telehealth appointments that are high quality as well. So those are my thoughts. Just there's a quality of care and health equity issue we really need to take into account such that we don't equate voice only with synchronized video.
Thank you so much, Dr. Franz. And we have Marty Carty from from OPCA, Oregon Primary Care.
Thank you. I just want to echo so much of what's been said today. I think we support access to healthcare through whatever modality works best for the patient and the provider relationship. One of the things that I was struck by listening to the previous speaker, Mr. Franz, was that, from our vantage point, when we think about synchronous audio video as compared to telephone only, it's really important for us to recognize that phone only, it's not the difference between a video visit or a phone visit. It's the difference between a phone visit and no visit based on the device that's provided. And so I think it's really, really important for us as we look at the future. Perhaps it isn't into perpetuity, but in the short term, until those tools and resources and infrastructure exist, and that we do provide every means possible for patients to access care at the level and at the place that they can. And the other thing I want to add is he also mentioned rides to care and other modes of transportation to their brick and mortar appointments. And I want to say this, in the absence of let's see, in the absence of access to broadband in many parts of our state, we have to pay for telehealth video via phone only. And it's also important to remember that it is a dramatically lower barrier to get someone set up with a reliable device to access telemedicine than it is to get someone set up with reliable transportation to access in-person care. Thank you.
Thank you so much. At this point, I want to just quickly reiterate, since we may have people jumping off the phone in just a moment, that there are currently open Medicaid rules, and we have a particular process for accepting comments for the Oregon Health Plan rules. There are both fee-for-service rules and also rules related to our coordinated care organizations. I'm just going to put the email again in the chat and just remind everyone again that the comments must be submitted via this email and are due by 5 p.m. this Saturday, November 21st. And for those who are on the phone and not in front of the chat, the email is hsd.rules@dhsoha.state.or.us. I just wanted to share that again, since there has just been such wonderful feedback shared today, and want to be sure that for those who have an interest in submitting that feedback, that they know the process of how to submit. At this point, I'm not seeing any additional names in the chat. I wonder, Jesse, do we want to throw out one last question, maybe related to kind of the uncertainty at the federal level before we close today?
Sure. So we only have a few more minutes, but one of the questions that we've been thinking about a lot is what Oregon can do in a context where we don't know what the federal government is going to do regarding HIPAA requirements around privacy and data security, and Medicare coverage requirements, which often move matters in the rest of the market as well. And given that we may not know for some months or potentially even years where the federal government is headed in this area, does anyone have any feedback on how the state should approach thinking about the interaction with federal policy? If not, that's totally fine, of course, but we'll give folks one more minute here. Also, if anybody has any other comments, feel free to jump into the chat, or if you're on the phone, unmute yourself and just chat.
We've been seeing, just to call attention to the chat from Sophia around the Federal Geek Squad. Since that was raised by one of the speakers, we've been seeing quite a few of you all, everyone participating, just reiterating that that sounds like a great idea.
Okay, well, we have about 5 minutes left, so I think we should probably transition into wrapping things up here. Thank you all so much for your engaged participation and for everyone keeping within their time. We really appreciate that, given how many people we had on. So please feel free to contact the agency folks involved here. The DCBS contacts are me, of course, and Katie Button from the Marketplace. Probably most questions related to telehealth for DCBS should go to me because the Marketplace has limited responsibility in this area, but if there's anything Marketplace specific. And then the OHA contact would be Amanda, and our emails are here. I'm not sure whether you can easily copy them when I'm sharing my screen here. So maybe what we should do is also put them in the chat so that people can get them there. And
Jesse, do you want to just read them out for those who are on the phone?
Oh, sure. So mine is Jesse E. O'Brien, so that's JESSE.E.OBRIEN @oregon.gov, and Katie Button's is Katie M. Button, that's KATIE.M.BUTTON @oregon.gov. And then Amanda's is Amanda M. Peden, AMANDA.M.PEDEN @DHSOHA.state.or.us. And again, we do expect to be posting a recording of this presentation on both the DCBS and OHA websites, and we'll follow up with those of you who we have email contacts for, and we can also send it out to some of our other sort of institutional contacts in the provider community, such as the Oregon Medical Association and other associations. So we can make sure that this gets out so other people can take a look at it. But in terms of those contacts, so Amanda has mentioned multiple times the rulemaking that OHA is doing. DCBS doesn't have rules in this area, and we don't have a rulemaking process right now, but we are seeking feedback on both the next steps for our voluntary agreement around pay parity and just generally any additional steps we could take to improve the telehealth situation with commercial health insurance. So if you have ideas in that area, please feel free to send me an email. Happy to hear from everyone.